Okay. Yeah. So now let us move on to the management of the inguinal lymph nodes. Okay. When you want to manage the inguinal lymph node, the first thing that you should know is the anatomy of inguinal lymph nodes. Okay. So how do you basically classify the inguinal lymph nodes?
Dessler has classified the inguinal lymph nodes, sir. It is basically divided into fascia lata. Above is superficial lymph nodes. Around 20 to 25 are there, sir. Below the fascia lata is deep inguinal nodes, sir. Around 4 to 5 are there. They are called cloacated nodes, sir. Superficial inguinal nodes are further divided by Dessler into 5, sir, based on the great saphenous vein joining into the femoral vein near the cribriform fascia. There are 3 main branches, sir. One is the external iliac branch, one is the inferior epigastric branch, one is the superficial external pudendal branch. The nodes between superficial pudendal branch and inferior epigastric vein are called supromedial, which are grade 1, group 1. The nodes along the circumflex iliac vein are called grade superolateral. The nodes along the lateral femoral vein are called inferolateral. The nodes along the great saphenous vein and between the femoral vein are called infromedial nodes. And the nodes on cribriform fascia where the vein is joining the GSV are called central group of nodes, sir. Grade 5.
So the first thing that you'll have to remember is it is not inferior epigastric vein. The 3 veins are superficial epigastric, which runs medial most. The superficial circumflex iliac, which is the lateral most. And in between, you have superficial external pudendal. So the medial most will be superficial epigastric. The middle one will be the superficial external pudendal. The lateral most one will be the circumflex iliac, superficial circumflex iliac. These are 3 main branches. Between the first and the second, between the superficial epigastric and the superficial external pudendal lies the node of Cabanas. That is the sentinel node. If you want to identify the sentinel node on table, that is the superior-medial compartment. You call it a Dessler classified this way. The widely accepted one is the Rouvier's zone, Rouviere, Rouvier's zones, which again are classified into 5 based on 2 lines drawn vertical line and a horizontal line intersecting at the saphenofemoral junction. We classified into 5 zones. The first one is superolateral, the second zone is superomedial, the third one is infromedial, the fourth is infralateral, fifth one is saphenofemoral junction. Okay, so as per the Rouvier's zone, they are located in the zone 2. Okay, but it doesn't matter whichever classification you follow. What you should understand is leave alone the numbers of zones, zone 1, 2, 3, 4. You call it superior medial compartment where the Cabanas node is located. Okay, superior medial compartment where the lymph node of Cabanas is located. So that much you should be very careful about, very clear about, because when you want to do a sentinel node biopsy, you'll have to identify these 2 veins, the superficial epigastric vein and superficial external pudendal vein, and identify the node or lymphatic tissue between the 2 and remove all the lymphatic tissue between the 2, which will pick up the lymph node of Cabana. Okay?
Yes, sir.
So now you tell me, what do you want to do? This patient has a T3 lesion. It is a T3, clinically N0, and radiologically M0.
M0, yes, sir. So,
radiologically means what radiology have you done here?
Ultrasound abdomen and chest X-ray, sir.
Chest X-ray. That is normal here. Okay. So what do you want to do now?
So bilateral superficial inguinal node dissection, sir.
Bilateral superficial. What incision will you make? You'll do a Catalona or will you do a Dessler?
Sir, only modified, sir. Modified Catalona, sir.
See, that also you should say. No, even in Dessler, you can do a radical inguinal dissection. Also, you can do a superficial inguinal dissection.
Yes, sir.
Okay. Where will you look for the superficial inguinal lymph nodes?
2 centimeters below the inguinal ligament, sir.
No. You are talking about the boundaries, sir. I'm not talking about that. I'm asking you the location. Location means the plane. Sorry, the plane. Where will you look for?
Above the fascia lata, sir.
No, when you go from the skin, how will you reach the fascia lata? Before you reach the fascia lata, what are the other structures that you'll have to pass through?
Scarpa fascia and campus fascia, sir.
Which is superficial, which is deep?
Sir, Scarpa is superficial, sir.
If you think you'll be 50% correct, it is always you are 50% wrong. So that is what we do now when you answer MCQs. We think we have ruled out two, the other two will be always wrong. It's always like that. So it is actually, remember it is CS, cross section. When you do a cross section of the thigh, C comes above, S comes below. The deeper layer is a Scarpa's layer. The superficial layer is a camper. Yes, Dr. Srinivasan, yes. C is first, S is next, S is
Yes,
deeper. The deeper superficial campus fibrofatty layer and deeper membranous scarpa. Okay.
Yes, sir.
Below that is the deep fascia of lata.
Yes, sir.
So you have camper first, then the scarpa next, deeper membrane of scarpa, then comes the deep layer of fascia lata. Okay.
Yes, sir.
Now you tell me, where is the lymph node located? Superficial inguinal lymph node located.
Sir, supramedially, sir.
No, the plane I'm asking.
Just below the Scarpa's fascia, sir. Before we go to the fascia later, the nodes will be superficial.
So when you do, it's very important for you to know this plane, because when you, please, all of you, please remember, listen carefully. When you do an incision, the plane is very important. The main difference, yes, is not superficial. Somebody has Samsung, somebody has written, yes, is not superficial. Yes, is deep actually. Deeper scarpa. Camper is superficial. Scarpa is deep, membranous layer. Please remember, when you make an incision, you first incise the skin. Okay. And then you reach the camper's fascia. Camper's fascia. It's a fibrofatty area. You then see the thick adipose tissue there. The lymph nodes are actually located on the adipose tissue or interspersed within the adipose tissue only. Superficial to the deeper membranous layer of scarpa. Okay. The lymph nodes are located between the skin above and the deep membranous layer. Between the two is located the lymph nodes. So when you make an incision, for your classical inguinal dissection, what you do is you lift up only the skin and entire fibrofatty layer you remove. Okay. Entire that fatty tissue, adipose tissue, everything you remove. The skin is skeletonized in a radical dissection. Whereas in a modified dissection, you go one layer deeper, the camper's fascia also you lift up, and only the fatty area, adipose tissue alone you remove. That means the skin along with the camper's fascia are lifted up, and only the adipose tissue is removed, leaving the deeper scarpa's fascia intact. That means in modified dissection, the skin and the camper's fascia are lifted up together, both are preserved, and the deeper membranous fascia is also preserved. Deeper membranous scarpa's fascia is also preserved. So in modified inguinal dissection, scarpa's below is preserved, camper above is also preserved. Camper along with the skin is lifted up together. That means the skin becomes a little thicker there and the vascularity is maintained there. The chances of one developing a skin necrosis is minimized. Because the skin flap that you take is a thicker one, which also includes the fascia of camper. It's very important for you to understand this, because inguinal lymph nodes are embedded, interspersed within the adipose tissue. You have camper's fascia above and this scarpa's fascia below. In between the two, you have the inguinal superficial group of inguinal lymph nodes located. So you will dissect out only those lymph nodes, leaving behind the camper intact above and scarpa fascia below. Okay, that is a modified inguinal dissection. The length and extent and all you should read about. How much centimeters from anterior superior, how much, all the pubic, all that you should.
Yes, sir.
Okay. So you are doing a bilateral superficial inguinal dissection. Okay. And you're going to send them for frozen analysis. Frozen. Okay. And then do what?
If frozen comes no lymphatic spread, sir, then that is the end we can observe the patient. Sir. If frozen comes positive for that side, then we have to progress to deep node resection with pelvic node dissection, sir.
I will give you a scenario here, not a scenario, this particular case itself. This patient has got a high-grade lesion. High-grade lesion, clinically non-palpable lymph nodes. Okay. Clinically non-palpable lymph nodes on both sides. If supposing a node is palpable on one side, what will you do?
If node is palpable on that side, we have to go for ipsilateral ilioinguinal node dissection plus contralateral superficial inguinal node dissection, sir.
But how do you know that this node is involved? It's a palpable lymph node only. But how do you know that this node is involved?
If it is high risk, there is 70% chance of nodal mets, sir. So we can go directly for the nodal dissection, sir.
Yes, that means you'll have to go for a deeper node dissection also in such instances, and also the ipsilateral iliac nodes. Whether the iliac nodes are enlarged or not, at least the iliac lymphatic tissue, everything should be knocked off.
Yes, sir.
Okay, so that is the, we'll go through the algorithm again at the end. Okay,
yes, sir.
fine, we'll do. That is the plan. If supposing this patient has got bilateral palpable inguinal lymph nodes, what will you do?
If bilateral nodes are palpable, we'll do FNAC first, sir. If FNAC comes positive, then we'll go for bilateral ilioinguinal node dissection, sir. If it comes negative, then we can do bilateral superficial inguinal node dissection. Based on that report, we can proceed, sir.
Instead, that is one concept. Instead, even if the FNAC is negative, you're going to go ahead with superficial inguinal dissection.
Yes,
why don't you might as well straight away go for superficial inguinal dissection then?
Then we have to wait for the frozen section and frozen section.
Even otherwise, you're going to wait only,
yes.
no?
Yes, sir.
No, I'm asking you.
Yes, sir.
Frozen will take half an hour. Frozen will take half an hour. No, if you have, see, this FNSC concept is applicable in centers which do not have the frozen section, which cannot be immediately done. There will be more time consuming, send it to another place and all that. In a center like yours, where you have the state-of-the-art pathology lab available, pathologist available nearby, you can always do a superficial node, send that for frozen, see what it is, take it from there. There you can always deviate from the protocol. It is not necessary in such a setting where there are bilateral positive palpable nodes. It is not always required to do an FNAC before you plan for superficial inguinal dissection. Because if it is FNAC positive, that side you are going to go for ipsilateral. In the negative side, what are you going to do? You're not going to leave behind.
Yes, sir.
You're not going to leave behind. You're going to do superficial inguinal node, isn't it?
Yes, sir.
In which case, might as well do both sides together. Because that side, again, you're going to wait for frozen only. That side, again, you're going to do frozen. You're going to wait for that. No.
Yes, sir. If it comes positive only, we'll proceed for
No, but you are going to wait for half an hour or 45 minutes.
Yes,
isn't
sir.
it?
Yes, sir.
One side you can finish faster, but the other side you are going to wait only.
Understood, sir.
So there is no real need for you to go for FNSC always. If you say FNSC, yes, guidelines say FNSC, agree. But it is not always necessary for you to be so rigid in the protocol. You can always deviate from the protocol, go for superficial inguinal both sides, simultaneously send it for frozen, and then take it from there. That also you can plan accordingly. Okay, fine.
Yes, sir.
Yes, Dr. P.V. Srinivasan, would you like to add anything more here at this point of time?
Clear, sir. Nothing, sir. Clear.
Now, this biopsy, if this lymph node biopsy comes as a ipsilateral pelvic lymph node positive, what next are you going to do?
If pelvic node comes positive, we have to give adjuvant chemotherapy, and also we have to do contralateral superficial inguinal node dissection, sir, at the same time.
No. Why I am asking this question is because this is where Dr. P.V. Srinivasan raised a very valid question. Role of PET CT. Would you like to do a PET CT here at this point of time? You want to give the patient an adjuvant therapy, isn't it?
Yes, sir.
So when you are giving an adjuvant therapy, how sure are you that there is no other metastasis anywhere else? I'm
pelvic
asking
lymph
you.
node, yes, sir. Pelvic lymph node will send to biopsy. So if there is extranodal extension, size more than 5 centimeters, we can go for adjuvant therapy, sir.
You can, Solapata, you can do anything you want. What will you do? Tomorrow, as a consultant, what will you do? That is what
Adjuvant
we need.
chemotherapy, sir.
Sorry?
Adjuvant chemotherapy. Adjuvant
Good.
chemotherapy, sir.
Will you do a PET CT at all or not?
For the response to the chemotherapy, we will do PET CT, sir, but not at that point, sir.
We will not do at this point, is it?
Yes, sir. Yes, sir.
Anybody else?
If we, sir, if we suspect any extranodal communication, then we have to do PET CT, sir.
Yeah, you can do, but you will not do. The consensus is that you will not do a PET CT here. When will you do a PET CT? Because the pelvic lymph nodes are considered as N3 group of lymph nodes. The pelvic lymph nodes are considered as N3 group of lymph nodes. N3 nodes. The pathological N3, the PN3 is pelvic lymph node. If there is any extension beyond the pelvic lymph nodes, which you pick up in the CT, if suppose you have nodes around the inferior mesenteric artery, if supposing there are nodes in the para-aortic or paracaval, then you need to know whether it is confined to that or whether it has gone to the mediastinal group of lymph nodes also, because many a time the X-ray test will not be able to pick up a mediastinal node. Many a time a small lung metastasis will get easily missed out near X-ray test. So X-ray test is only an initial screening tool. X-ray test will only tell you whether they can safely give you a general anesthesia. That's all. X-ray test will
Yes,
not
sir.
tell you whether there is a bony metastasis. So a patient who has got in CT abdomen, if supposing there is a node which is enlarged beyond the N3 level, beyond the pelvic group of lymph nodes, if supposing there is a node which is there in the inferior mesenteric artery, if supposing there is a node which is there in the common iliac artery, if supposing the node there is pericaval, paracaval, intra-aortic cable, para-aortic group of lymph nodes, the diaphragmatic, retrocrural group of lymph nodes, then a PET CT will definitely be useful, because you need to actually prognosticate this individual before you plan for an adjuvant therapy. Isn't it?
Yes, sir. Yes, sir.
That is the role of a PET CT. But otherwise, PET CT, as you rightly mentioned, has not got any role to play as of now. If you are comfortable with the reporting of CT, then there is no real need for you to go for a PET CT at this point of time. Again, as you rightly mentioned, as a follow-up, to see if the response to therapy, you will always do a PET CT as a follow-up. Okay?
Yes, sir.
But if you believe in the concept of doing a PET CT straight away, nobody will question you. Why you are doing a PET CT? Nobody will question you. Okay?
Yes, sir.
So PET CT, the actual indication for a PET CT is post-surgery, post-adjuvant therapy. If there's a recurrence, you will do a PET CT. Or if the patient has got an M1 disease already, then you will do a PET CT.
Yes, sir.
Okay?
Yes, sir.
Fine. Srinivasan, is it clear, PV?
Very clear, sir. Thank you, sir.
Okay. So we will... So that is okay, fine. What is the next? You said adjuvant chemo. If the pelvic lymph nodes are enlarged, you will give adjuvant
Positive.
therapy, you said.
Yes,
Isn't
sir.
it? What
Yes, sir.
adjuvant therapy will you give? How will you give? What will you give?
The cisplatin, ifosfamide, paclitaxel regimen will give, sir.
That is called as a
3
TIP
cycles.
regime.
TIP
Called a TIP
regimen.
regime.
Yes, sir.
Where else have you heard of a TIP? Heard of a TIP in hypospadias repair?
Yes, sir.
Where else have you heard
Yes.
TIP? Tubular incised plate. TIP.
Yes.
Snodgrass procedure. TIP. Okay.
Yes,
So
yes, sir.
TIP is what? The 3 drugs. What are the 3 drugs you mentioned?
Paclitaxel, ifosfamide, and cisplatin, sir.
It's basically a platinum-based therapy. The earlier
Yes,
treatment was VBM, vincristine, bleomycin, and methotrexate. Because of the
yes, sir.
toxicity that the bleomycin produced, and because of the reduced efficacy of vincristine and methotrexate, which is only about 30 to 60% response rates, they have now moved beyond VBM to TIP, that is platinum-based, cisplatin, ifosfamide, and paclitaxel. Okay.
Paclitaxel.
So that is the treatment of choice for, and how much of TIP chemotherapy you give, how many cycles you give. Read about all that. Okay.
Yes, sir.
Now,
Yes, sir.
how will you follow up the patient after you give chemotherapy?
Sir, we need
4
to
cycles of
do.
adjuvant chemo are given. Okay.
Yes, sir.
Now the patient is coming back to you
Yes,
from
sir.
medical oncology department saying, Doctor, they have told me to go back to general surgery, sorry, to urology now. Okay. So what will you do now?
Every 6 months we need to do scans, sir, in first 2 years.
Oh, when you say
After
scan,
first
what
year,
scan will
we
you do?
need to do yearly scan,
What scan will you do?
cross-sectional CT scan, sir.
You will do an axial imaging only.
CT scan, sir. Minimum of CT scan. Yes, sir. Yes, sir.
Will you
6
not do a
monthly
PET CT
for
here?
one minimum of CT, sir. We can do PET CT in follow-up, sir.
Don't say I can. Don't say I can. What will you do?
CT will be sufficient, sir. PET CT will not give additional information, sir. If there is
If the
no
patient, no. If the patient has had a pelvic lymph node which you have excised that is positive, you have given adjuvant therapy. The role of a PET CT PET CT has got a greater role to play because the PET CT in post-treatment restaging to see if there is any residual disease or if there is a recurrence after lymphadenectomy or after chemotherapy or after radiotherapy, if there is a recurrence, PET CT will definitely be useful. Okay?
Yes, sir. Yes, sir.
PET CT will be useful. You can also say that I will not do a PET CT, but I will do only a plain CT. But if that plain CT picks up a 3 centimeter mass, then to see if there is a fibrotic mass or to see if there is any viable, then I will do PET CT. Examiner will still accept that as an open mind.
Yes, sir.
All that you should remember is that PET CT is not mandatory in patients with CFNS.
Yes, sir.
PET CT you will do only when there is an additional information required where the existing CT is giving you an inadequate information.
Yes, sir.
Is that clear?
Yes, sir. Understood, sir.
Is there a role for radiotherapy at all?
Radiotherapy, if for the organ preserving surgery, if the tumor is less than 4 centimeters, we can do radiotherapy, sir. In a low risk individual.
Anything else? Any other role for radiotherapy? One is organ preserving. Okay.
Yes, sir.
Then, is there a role for adjuvant RT?
If margins comes,
Sorry?
there's no role, sir.
Very good. Yes. If supposing the patient has got positive surgical margin, you have done a total amputation of penis where there is still some positive margin. Okay. Where again going back and re-excising is not possible. Or the lymph nodes that you have dissected, if there is an extranodal extension. Okay.
Yes, sir.
There is a role for adjuvant therapy. So
Yes, sir.
radiotherapy can be either a definitive therapy in patients with organ preservation or in patients who are unfit for surgery or who refuse amputation. A superficial exophytic lesion, external beam radiotherapy can be tried. Okay. But please remember, radiotherapy is not the treatment of choice for these individuals. It's primary surgical excision only. Okay. Or it can be given as an adjuvant therapy or as a palliative therapy. Patients with large, locally advanced, ulcerated, inoperable tumors, you can always go for a
Radiotherapy.
radiation also. The radiation can be either external beam radiotherapy or brachytherapy. Or these days, the electron beam therapy also they give. No? So read about all that, types of radiotherapy,
Yes, sir. Yes,
give
sir.
and all that. Okay, you should read about all that. Okay.
Yes, sir.
This covers mostly. CFNS will be a short case for you. The discussion can go in any direction for that matter. They can go into the lymph nodes, the anatomy of the lymph nodes. They can go into chemotherapy. They can go to radiotherapy, or they may give you various scenarios and just ask you to discuss all that. No, they can ask you to discuss. They will give you various clinical scenarios. Okay. Should inguinal lymph node dissection be bilateral for patients with unilateral adenopathy? If you have a palpable inguinal lymph node on one side, do you need to do on both sides?
But
Bhavya.
superficial, at least we need to do, sir. Because crossover
Yes.
of the lymphatics at the base of penis happens, sir.
Very good. Because there is a crossover which can happen at the root of the penis, Even if there is one side enlarged, there is a possibility that the other side may also get involved. So you should go for a superficial dissection of the inguinal nodes on both sides, not just unilateral. Okay.
Yes, sir.
Should a pelvic lymph node be removed in all patients with inguinal node metastasis?
No, sir. If the projection section shows, if the size of the node is more than 3 centimeters, if there is extra nodal extension, then only we need to do the pelvic node dissection, sir.
What are you talking?
Sir, when the deep nodes are more than 3 centimeter with extra nodal extension, sir, then the
If there is if there is a 1 centimeter node, will you not do? If it is metastatic, you are doing a superficial inguinal dissection that comes as positive for malignancy.
We need to do that, sir. Yes, sir.
We need to do only. So you won't apply the size criteria there. If suppose you have done only a superficial dissection, and then if there are number of nodes are more than 3, and if the node is more than 3 centimeters, or there is an extra capsular extension, then you'll have to go again and do a pelvic lymph node dissection.
Yes, sir.
You understand?
I understood, sir. Yes, sir.
If supposing the patient has got a low-grade disease, a small solitary lymph node with no extracapsular extension, you can avoid a pelvic lymph node dissection. That also you should remember, and you'll have to put them on follow-up.
Follow-up, yes, sir.
Okay. You have done a biopsy, you have done an edge-wedge biopsy, and the biopsy report comes as verrucous carcinoma. How are you going to manage them?
Verrucous comes under a low-risk individual, sir. We can do organ-preserving surgery. No need to do nodal dissection, sir. Observation, sir.
Is it because it is a low-risk category that you will not do a lymph node dissection here?
A tumor itself is a large tumor cell, sir. It cannot invade into the lymphatics to spread.
Very good. The cells are too large to permeate into the lymphatics. Hence, you don't have to dissect those lymph nodes. If supposing the node is positive, what does that mean to you?
Superficial. In this scenario, it may be a superficial infection, added infection, sir, because it's a large tumor.
No. If there is a verrucous carcinoma and if the lymph node is positive, that means there is some other squamous cell carcinoma element hidden somewhere else, deeper inside.
Yes, sir. Yes, sir.
That is what you should remember.
Yes, sir. Yes, sir.
Okay, I think that covers most of the CAPness. And anything more you would like to add, Dr. P.V. Srinivasan, Dr. Srinivasan Ganesan? Hari?
Sir, I want to know something about the follow-up of patients after this bilateral block dissections.
Yes.
How to follow this patient? What are the problems we can expect and how to manage them?
Yeah, Bhavya.
Sure. Lymphoria, lymphedema are the most common complications occurred post-dissection, sir. We need to advise for crepe bandage, lymphatic mobilizations, lymph massages should be advised for the patients. Infections are most common, so we need to give prolonged antibiotic post-operative period. Once the patient has recovered from post-operative period, follow-up should be done for 1 year, every 6 months. Cross-sectional CT is the must, sir. After 1 year, yearly for next 5 years, cross-sectional CT, sir.
Is there any way, you said lymphoria, lymphedema, infection, flap necrosis, again, another one that you missed out.
Yes, sir.
All these are common ones. So how can you prevent all this from happening?
Sir, the Catalona modification, if you do, the complication rates will drop down, sir, because we are leaving the campus fascia with the flap. So flap necrosis is less. Our restriction of lymphatics will be until femoral artery. So thigh lymphatics are not touched. So lymphoria, lymphedema chances also less, sir.
No. There is one way of answering. But in not all individuals will have luxury of doing only a modified or a Catalona dissection. There may be instances where you may have to go for a radical approach, just as a dissection or a classical dissection also. In which case, how will you prevent all this lymphedema, lymphoria, infection, flap necrosis, everything? Are there any flaps that you can talk about? No. You're talking about the differences between modified. We'll come to that later. No. I'm asking, is there any way by which you can raise a flap and cover that area to push the gap? You can do a skin grafting, simple skin grafting you can do to bridge the gap, provided you have a good bed where inosculation will be possible. Otherwise, the graft will go for necrosis. You can do a sartorius transposition, and you can have a nice bed which can cover the great vessels. Over that, you can place a skin graft also and cover whatever bridging is required. You can do releasing incisions laterally and bring the skin and the myocutaneous thing medially and bridge the gap possible.
Yes, sir.
Or you can do a tensor fascia lata flap also. You can do a rectus abdominis flap also. All these rotational flaps again. I'll read about all these flaps also.
Yes,
Okay,
sir.
which can all be used to bridge the gap so that you will be able to avoid all these complications, minimize the complications. Okay.
Yes, sir.
Have a good, nice sartorius transposition. You decide you don't do extensive dissection of the great saphenous vein. The lymphatic channels along that will also be preserved. Lymphoria will be less here. So modified dissection, as you rightly mentioned, the chances of skin necrosis is less not because the dissection is not extensive, it is because the skin flaps are thicker here.
Thicker.
In modified catalonia dissection, you raise the skin along with the campus fascia so that the flap is thicker, so that flap necrosis is minimized there. Okay, and there is no need for a sartorius transposition there, and there is no need for a tensor fascia because the dissection is only limited to only the superficial group of lymph nodes here.
Yes, sir.
Okay, so that is what.
Yes, sir.
But what Dr. Srinivasan asked is not this. He asked, how are you going to follow up? You have done a wonderful procedure. You've done a great, excellent ilioinguinal dissection. What next? That is what he is asking. You mentioned that, but you just ran through. Can you just go step by step and explain?
Yes, sir. Yes, sir. Post-op period, once the patient recovers, sir, every 6 months for the first year, we need to do a minimum of cross-sectional investigations. A CT, minimum of CT scan we need to do, sir, first 1 year. Then yearly CT scan for next 5 years, sir.
Axial imaging is important for the first 1 year. For the first year, that means you do it twice. Okay, every 6 months you do axial imaging. If at all CT abdomen is a little suspicious, you go for a PET CT straight away. There should be no restriction in the usage of PET CT at all. You cannot assume that PET CT will be useless. That should not be the take-home message here. PET CT you will use with utmost caution only when the CT scan, say regular CT's abdomen is equivocal. But if you have an equivocal one, then there is a little what do you call that? As if it's not so informative, you should never ever hesitate to go for a PET CT. Whole body PET CT is always you should have a lower threshold for asking for a PET CT in such instances. Okay, and this follow-up should be more intense. Every year you'll have to follow them up to 5 years, and then every alternate years for another 5 years. Okay. So at least for the next 10 years, because CA penis is one where you aim at cure of the disease. You don't talk about giving a better quality of life. You talk about the cure of the disease. CA penis. Once you have done a proper job, you can actually aim at cure. Okay. So the follow-up has to be more careful, more intense, more regular, and more methodical. Okay.
Yes, sir. Yes, sir.
Hope that answers your question, Dr. P. Srinivasan.
Yes, sir. Fine, sir.
Anything else, Dr. Srinivasan Ganesan? Would you like to add anything more? And then you'll have to also know about the differences between a regular and classical and a modified. What all you do in classical, which you do not do in modified. Can you list out all that?
Yes, sir. First, incision will be 20 centimeters laterally, 15 centimeter medially, sir.
Okay, dimensions are less. Okay, number one.
Yes,
number two.
The flap will be carpus and campus both involved, sir. Whereas in modified, only campus is left with the skin, sir. Great saphenous vein is not sacrificed in the Catalona, sir. Okay. Sartorius transposition is not required in Catalona, sir. And the medial extent of the dissection is until femoral artery, sir. Whereas in the Deslers, we will go all along the beyond the femoral artery, sir.
Fine.
And the inferior border is restricted until the line joining the fossa ovalis, sir, for the dissection in Catalonas.
And then if you answer everything, they will ask you the TNM staging, which you should know very well. And then if you answer TNM staging, they will ask you Jackson staging. Jackson also you should know. That's a clinical staging, though not being used these days, but still you should be able to, because when you answer everything, the examiner would like to stop at a point where you fumble or not answer, and then you tell the examiner, sorry, sir, I'm not aware of it. And then they'll have to stop the discussion. No? Jackson staging will be used for that also. Okay.
Yes, sir.
So all these things you should know. Okay. When to do a CT, when to do a PET CT, all that you should, role of PET CT, everything you should know. And what is the role of uh, gene therapy here? Is there anything called a genomic study here in CAPNS?
Extensively for HPV diseases, there is a genomic therapies involved. So CDKN, TP53, E-cadherin, all these things are there for the HPV related diseases, sir.
Okay. And then you should also, when you talk about chemotherapy, you should also talk about the immune checkpoint inhibitors also, because there is one recent advance. There may be a question on that, 10-mark question, theory question also for you. You should talk about this, what is it? The ligand 1, what is it? PGDL1, the anti-PGL1. Huh? All those things you should immune checkpoint inhibitors for all that you should be aware of. Please read about all that also, because when you
Yes,
talk about
yes,
chemotherapy, they will ask about PD1, PDL1 inhibitors, checkpoint in anti-PD1, anti-PDL1. All
yes,
that
sir.
you should be able to answer as well. Okay.
Yes, sir.
Can you share the Venkatesh? Can you share the slides? Dr. Srinivasan, is there anything more? Dr. Srinivasan said no thanks. Okay. Dr. Piyush, anything more you would like to add, PVS?
No, sir, nothing, sir. Everything
Okay.
completed.
I've got a few slides with me. I will just run through those slides in the next 5 minutes. Some important things alone I would like to highlight here, and then we will wind up around 12, 12, 5, 12, 10. Okay. We are trying to get some TNMC credit points every time. So I think all of you who have participated in the last one would have got the TNMC certificate by email. And each one of you, I'm sure you must be having a login ID for TNMC. Also, you can go through your login ID and then see what all other certificates have you got in your name. All that will be archived in your TNMC login portal. Okay, you can just verify, cross-check also. Okay, so condyloma acuminata, the first Bhavya presented this condyloma acuminata as one of the diagnoses. It's very important for us to know this particular diagnosis, because many a time we'll be thinking it is malignancy, but it will turn out to be only a condyloma acuminata. So many times we have seen that also happen. Because if it is a benign lesion, there is no real need for us to go for an extensive surgical procedure, where either the edge-wedge biopsy will help you, or the presence of certain histological pathognomonic findings also will point towards HPV. The presence of coilocytes, very important for you to know this particular finding. The presence of coilocytes, perinuclear halo, which is pathognomonic of HPV. Okay, it's an empty cavity. What is a coilocyte? It's an empty cavity surrounding an atypical nucleus. Nucleus will be atypical, and perinuclear there will be an empty cavity or a halo. A perinuclear halo, that is coilocyte, they call it. Okay, so they will ask you all these things, and then you should know the treatment for condyloma acuminata. What are the various topical treatment that you can? What are the adjunctive therapies? All this you should know. Okay. And then the Bushkill-Lowenstein tumor, which Bhavya was talking about initially, also called as giant condyloma acuminata, um, same as condyloma acumulatum. Again, the HPV 6 and 11 are involved in that. It's more of a theory only. But you can just go through. We'll share the PowerPoint also. You can just run through this PowerPoint, not for a clinical discussion, but for your basic understanding. You should know this. Okay, fine. What is this? Yes, they will sometimes ask you what is the role of circumcision. See, basically, what you should remember is that pediatric circumcision is not protective, whereas neonatal circumcision is highly protective. That one you should know. Okay, neonatal circumcision is protective. Pediatric or an adult circumcision does not give you protection. The only thing is the prepuce is removed so that if at all there is a lesion, it will be seen early. So that way, circumcision will be helpful, but it is not protective. Okay. So EAE guidelines say that circumcision before puberty reduces the lifetime risk. NCCN says that it's just a proven factor, preventive factor, and it is not necessary that circumcision need to give protection all the time. So there is a slight discrepancy between EIU and NCCN, but what you should understand at your level is that neonatal circumcision is really protective. Adult circumcision does not give you that much of a protection. Okay. And then the HPV, what types of HPV, 16, 18, 31, 30, which all produce an oncogenic lesion. HPV 16 is most invasive and metastatic. All this you should know. E6 and E7 HPV that Bhavya was talking about. All those things you should know. Okay, I will just run through all this. These are not for the clinical case discussion, but sometimes randomly somebody may ask you which type of HPV can produce this, that, and all that. And then tobacco, we talked about smoking and CA penis. So tobacco per se can cause the compounds of nicotine, all that can produce an abnormality in the P53 mutation, and it can also elaborate on the VEGF pathway. Thereby, it can tobacco directly and indirectly both can produce CA penis, which we discussed in RCC and CA bladder also. The same way, tobacco can cause lesions in the penis also. You should know about lichen sclerosis heterotrophic BXO, which can be a pre-malignant one. When we discuss the pre-malignant lesions of the penis, which can be a differential diagnosis for CA penis, all this will be discussed. The examiner may stop at one of these. Yes, okay. All this you should know. This is just for we prepared for some other class, and then I thought, okay, fine. This is very important here. The grading of CAPNS. We talked about mild, moderate, and severe degree of differentiation, de-differentiation, and all that. So the three parameters that are taken into consideration are the degree of keratinization, the keratin pearl formation, the pleomorphism that you see in the nucleus, and the extensive mitosis that you get in the cells. These three will help you to distinguish well differentiated from moderately differentiated and from poorly differentiated. So basically, you should know one broader classification, Maichi et al.'s classification. Both are historical now. What we have is actually the WHO classification, which is well differentiated, moderate differentiated, and poorly differentiated. There is G1, G2, and G3. Okay, this is the widely followed these days. But if you answer WHO, sometimes the older examiners who are still following Maichi or broader may ask you what these are. So it is better that you know a little bit about broader and Maichi, but you should know about because all your planning of management, everything will be decided based on the WHO classification, grade 1, 2, and 3. Okay, that you should know. And the role of ultrasonography, role of role of MRA with artificial erection improves the delineation of tunica albuginea corpora, but not required actually. Only when you want to do an organ preservation surgery, it will be useful. Otherwise, by and large, there is no need for you to differentiate preoperatively involvement T1 lesion, subepithelial connective tissue, TA, and all that. No need, no, not TA, in situ. There is no need for you to differentiate that way. You can always do edge-wedge biopsy and then a partial penectomy be done with it. Then all this we talked about the role of CT and one important thing that you should know about is this LNMRI, lymphotropic nanoparticle MRI. It's something which you should. Sorry. And then Dr. Srinivasan was asking about role of PET-CT. PET-CT is very useful. Only select scenario. We discussed all this. You can go through this in the end. All this has been discussed. And PET-CT has got no definite role to play in the initial setting. Only for the follow-up or when the CT imaging is equivocal, then PET-CT will probably play a role. Otherwise, there is no need for you to go for PET-CT. PET-CT, which PET-CT you want to do, FDG PET or FDG PET or PSMA PET. Advantage and demerits and merits of each of these, you can just go through them. Okay. FDG PET remains still a clinical standard. PSMA PET is a promising adjunct under research protocol. The PSMA PET is something which I was mentioning. No, it's a glycoprotein which is expressed not only in prostate cancer, but also in other solid tumors, especially the laryngeal tumors, squamous cell carcinoma of the vocal cords, head and neck, cervical cancers, and CA penis, where all you get the squamous cell carcinomas, PSMA has got a role to play also. So I think probably someday PSMA PET will replace this FDG PET for CA penis also. Who knows? Okay. So the specific take-home message for PET-CT, role of PET-CT is PET-CT is a useful staging mainly for restaging in CAPNS, especially for node positive metastatic disease. If the nodes are positive, if the pelvic nodes are positive, and in addition to that, if you have a further proximal node which is enlarged, then probably you should go for a PET-CT. It does not replace CT or MRI. Okay, it only if you instead of CT, if you wanted a PET-CT, nobody is going to question you, but it does not replace the value or role or utility of CT or MRI. Main role plays in detecting, it plays a major role in detecting the distant metastasis, in diagnosing and detecting the distant metastasis, and to assess the treatment response. If there is a node which has been treated, if supposing there is a fibrotic mass which you are not sure whether it's still harboring malignancy inside or not, then you can do a PET-CT. It's same similar like a teratoma which you treat. Subsequently, you do a PET-CT to see if there is a growing teratoma or if there's a fibrotic material inside. All the testicular tumors you do the same way, it has got a role to play also. And when you do, we'll be optimizing the timing. That is 4 to 6 weeks after surgery. After you do a primary treatment, 4 to 6 weeks later you do, because you want to minimize the inflammatory uptake. So you wait for a minimum of at least a month before you do a PET-CT. All these things are, you should know the nomenclatures which have been changed now in this WHO ISUP, this International Society of Urological Pathologists. No, they have changed the grading. TA is now including the non-invasive localized squamous cell carcinoma, TA lesion. It was initially a verrucous carcinoma. Now they have included non-invasive. That means if it is not invading the subepithelial connective tissue, that's again a TA lesion. TA lesion need not necessarily be only verrucous carcinoma. Even a non-invasive localized squamous cell carcinoma of penis is included in TA. And then T1A, T1B, we discussed presence or absence of perineural invasion. We discussed all that. And T2 lesion is spongiosum invasion. That is the urethral involvement, spongio. T2 lesion, corpora cavernosa becomes T3. And then you should know what is PN1, PN2. N3, I said pelvic lymph nodes. PN1 is less than 2 unilateral, no extranodal extension. Or 3 or more than that unilateral, or if it is a bilateral, it becomes an N2 disease. So all that differentiation, the latest TNM staging has made all these changes. I'm sure all of you would have read your Campbell latest edition, which will give all these things. Okay. Management, again, based on this TNM, which we discussed in detail, actually. All this we have discussed. Just run through that. I will share the slides. Risk stratification, either you can do EAU or widely followed as the AU risk stratification or the NCCN guidelines. Some say low risk, intermediate, and high risk. Some have included a very low risk group also. Whichever you believe in, it's always safer to have 3 risk groups, low, intermediate, and high risk, and plan your treatment accordingly. What you should understand is that if there is a lymphovascular invasion, or if it is a poorly defined, it's a T3 lesion, even if it is a T1, there is a 50% chance that there can be occult node metastasis. 30 to 70% chance that there may be a nodal metastasis. That will justify the need for bilateral superficial inguinal dissection, sending it for frozen and taking it from there. So high risk individuals, you can always do a superficial bilateral. And the algorithm which Campbell we have discussed all this in detail. If supposing you have a fixed nodal mass, or if there is more than 4 centimeter mobile node, it is if you have a 5 centimeter mobile node, you will not do a you will not do a highly inguinal dissection straight away. You'll go for an induction chemotherapy, see how the response is, and then take it from there. Okay, you will not do straight away. In such, if it's a fixed node, or if it is a large node, even if it is mobile, or if you have got extensive pelvic node metastasis, then probably you will not go for a inguinal dissection straight away. There are some instances where you can go for watchful waiting also. If supposing there is only CIS, and if you've removed that, if there is a verrucous carcinoma where you are pretty sure that it is not going to harbor any underlying malignancy, underlying squamous cell carcinoma, I'm sorry, underlying T1 lesion, then you can always safely follow surveillance here. You can always wait and see whether it progresses further. A T1 G2 lesion that lacked vascular invasion. That also can be, if you want, you can follow it. There is no need for you to go for an extensive procedure after this. FNAC, there are pros and cons of FNAC. You can read about all these things. Okay. The load of sentinel node, we talked about sentinel node, where to look for a sentinel node, how reliable it is or how unreliable it is. And people talked so much about sentinel node, and finally I've given it up because only about 30 to 50% of these individuals will have sentinel node involvement. Rest of the 50% can still bypass. That means 1 in 2, there is a possibility that the sentinel node need not be involved, but still they can have rest of the inguinal nodes positive. So you should be a little careful about uh, attributing the staging to the presence or absence of a sentinel lymph node. So you have to be a little careful about understanding the statistics of sentinel node biopsy. This is very important. Dynamic sentinel node biopsy. This may be asked, though not practically used anywhere. I've not seen anybody doing this. I've not heard about anybody doing this, but still, it is something which is doable. It is possible. The only thing is you'll have to do it in 2 stages. The first stage, you may have to inject technetium labeled nanocolloid at the lesion. And then 6 hours later, you'll have to wait for 6 hours for this technetium labeled nanocolloid to reach the lymph node. And then intraoperatively, just before starting the procedure, you may have to give methylene blue also by the side of the lesion. And then 15-20 minutes later, you'll have to identify the node which is taking up this blue and then look for presence or absence with the gamma camera. You can also look for the presence of technetium labeled nanocolloid in that particular node and see whether the node is involved or not. If supposing the node takes up technetium labeled nanocolloid and if it is staining blue also, the probability of harboring malignancy is very high there. That is something which you will be able to pick up the sentinel lymph node with highest degree of accuracy. But the problem here again is that the sentinel node per se has got its own pros and cons. So nobody does that these days. Instead, straight away go for superficial inguinal dissection, which will remove all these nodes en masse. Head for frozen, take it from there. And in all the scenarios we discussed, should inguinal lymph node be dissected for bilateral for patients unilateral? Yes. All this we discussed. Verrucous carcinoma we discussed. Role of CT scan we discussed. Jackson staging also. And then the Rouvier's classification, you can talk about Dassler, you can talk about Rouvier's zones. All this you should know how they are being classified, superior medial, inferior medial, and all that. Then the deep inguinal lymph node significance, the Rouvier zones, this anatomical arrangement you should be very familiar with, and the extent also, how much superior limit, inferior limit for each of these Dassler and the Catalonis modification you should know. This is the most important thing you should understand. I was talking about repeatedly, I was highlighting. You have the skin here. Are you able to see my mouse running? You can see the superficial. This is the skin. The blue line is the skin. This
We are
yellow
able
one
to
is
see,
the
sir.
this yellow one is the adipose tissue, and then you have the membranous layer, and then you have the deep fascia of thigh. Okay, this is the fascia lata. The deep fascia of thigh is fascia lata. Once you make an incision on the skin, you lift the skin along with the campus fascia together. You lift the skin and the campus fascia together as a flap so that all the fibrous tissue, all the fatty tissue, everything will be removed en masse, which will contain the superficial group of inguinal lymph nodes. So that the deeper membranous layer of carpa is left behind intact along with the deep fascia layer. So the modified dissection will remove only the fatty tissue, leaving behind both the superficial layer of camper and the deeper layer of scarpa intact. Okay, that is the anatomical arrangement should be all familiar with. And then Bhavya talked about the differences between a modified and the classical dissection, which all you preserve. All that we discussed. This is the group of lymph nodes, the deep lymph nodes, and radiotherapy we talked about, external beam brachytherapy, electron beam therapy is also important. People use electron beam therapy these days for CA penis. Radiotherapy for the lymph nodes, radiotherapy for the primary lesion, both you should know. How much of grace do you give, how much dosage, how much duration, all that you should know. And chemotherapy. Chemotherapy can be a neoadjuvant chemotherapy. We discussed everything. I'm just running through all this because we already discussed everything in great detail. Talk about neoadjuvant therapy, talk about adjuvant therapy, palliative therapy, and concurrent chemo radiation, trimodal therapy, excision followed by chemo radiation. All these are platinum based. Earlier it was all VBM, it was all bleomycin, vincristine, and methotrexate based. But nowadays we are giving only TIP. TIP is paclitaxel, is ifosfamide, and cisplatin. That's the standard of care. VBM versus TIP. You should know VBM has become historical. It's only TIP which we use now, or we can use DP. It's not TP. DPF, docetaxel, cisplatin, and 5-fluorouracil. Okay. And then lastly, about immune checkpoint inhibitors. You know, immune checkpoint inhibitors can be a 10-mark question for theory question for you. I think we come to an end of today's session. Yes, Dr. Srinivasan?
Sir, I have one doubt, sir.
Yeah, Srini. Yeah, tell.
Is there any role for HPV vaccination in preventing CAPD, sir? As in CS cervix, nowadays gynecologists prescribe. Is there any role, sir?
For men, you are asking, is it?
Yes, sir. Yes, sir. The same squamous cell carcinoma, to prevent squamous cell carcinoma of cervix, gynecologists are using HPV vaccine. Is there any role? Can we use the same in male also?
I'm not aware. I'm not sure. Bhavya, can you, if you have an answer for this, can you explain?
Yes,
No, I don't have answer. That's why I'm searching for things.
No, I'm asking Bhavya. Bhavya, I'm asking. Bhavya is a presenter.
HPV related alone, it will protect, sir. Gardasil and Cervirax. And Gardasil new variant with 9 strains have come, sir. But all these things are given below 15 years or 15 to 25 years age men, sir. And it will protect only HPV related CAP, sir. Not non-HPV related, it has no role, sir.
Yes.
So there is a role for vaccine here also. Okay.
Okay, sir. Okay, sir. Thank you.
That's what you say, Bhavya?
Yes, sir. 15 to 25 years, sir. Gardasil can be given. Less than 15 years, 9 strain variant of Gardasil has come, sir.
Okay.
Which can be given, sir.
So there is a role for vaccine here to prevent and protect HPV-induced CAPs.
Yes.
Okay. For all other tobacco-induced and other incidental ones and all sporadic ones, that has got no protection against them. Okay, fine. Yes. Anybody else would like to add anything more? Any doubts you have? You can get them clarified.
Sir, chances of secondary malignancies following chemotherapy. Is there anything like that, sir? Cisplatin-based chemotherapy we are giving. Chances of secondary malignancy in long survivors.
I don't have personal data on that to tell you. Maybe I can look it up and maybe we can discuss that in the WhatsApp group. You're in that group, no, Dr. Srinivasan?
Yes, sir. I am in the group, sir.
Maybe we can discuss that also.
Sir, any role of most micrographic surgery in early lesions like in situ?
Yeah. This has all become actually historical.
Yeah.
No. It has all become, nobody does that. It was a very fancy question in our PG days. And everywhere they have actually given up all that now. Now there is no very limited role for all those layer by layer resection, excision, and then sending it for pathological examination. See how deeper you go, how minimal deeper you go, and all that. People have actually given up all that now because of a very high recurrence after all that.
Yes.
Nowadays they don't do at all.
Okay, sir.
Maybe centers which exclusively do all this stuff, no? Maybe they are the ones who are probably practicing all that. I don't think there is any center which does most micrographic surgery. I'm not very sure. But by and large, if you see all the urologists here, nobody does all that. May also be because the presentation is very delayed here.
Yes, sir.
Possible. That is also again another possibility. But yeah.
Thank you, sir. Thank you.
Vivek, would you like to add anything more, Vivek? You can see Vivek there and
that's pretty much, sir. Yes, sir.
Yeah, with your
about everything. Yes, sir. Yes.
Yeah, would you like to add anything more, Vivek? No, fine.
Sir, one question, sir. When we are doing a total penectomy, are we routinely practicing orchidectomy while before doing a perineal urethroplasty?
No, orchidectomy has got no role to play. No, absolutely no role to play at all. There are people who do orchidectomy. Along with that, to give a good perineal ureterostomy, people do orchidectomy. There are very few people who do orchidectomy. Maybe a couple of months ago, we had a heated debate in one of our education groups here also on whether orchidectomy really need to be done or not. Orchidectomy is not indicated. Do it, not do it is your individual choice, but it has got no role to play.
Okay, sir. Thank you.
Yes, sir. Srinivasan, sir. Good to see you here.
The orchidectomy role actually originally when we were general surgeons, we were posting the patient what we call as emasculation. Post we tend to, because generally there is a discussion that if there is no penis, there is no role for testis. But I don't think that statement is really true, because testis has got the testosterone has got actions on more than one organ. See, not only the androgen has got benefits over the bones or the improvement of hemoglobin, etc., etc. So it's not only for sexual function. So it's needed for other organs as well. So I don't think there's a role for orchidectomy unless there's infiltration or involvement of the scrotum or the testes or whatever. So that is one important point.
I think we can have it as a blanket statement here that it has got no role to play. But if as an individual surgeon, they have a preference to knock off the testes, I don't think we can say anything about it, because that is their individual choice. There were a few oncologists in the place where I got trained. They were routinely doing, in Royapeta Hospital, they were routinely doing orchidectomy also. But these days it is considered as a brutal
thing is, the
offense.
consenting is the issue, because as a patient, most of them who come to government centers are not very well educated and they don't know much, so they leave it to us to decide. So we are like not only a surgeon, like a person who guides them towards the right form of management. So we are more responsible in taking that decision. So personally, I don't think I will do an orchidectomy, but however, as you said, it's individual choice based on various factors.
Very true. Yes, there is another question raised here. Vivek, do you practice radical penectomy in your center, Vivek? Is there anything called a radical penectomy? Somebody has asked a question. Radical penectomy should be done at what time, sir? Vivek?
No, radical penectomy is including the crura as well, sir. Going till the crura and then cutting across and then doing the surgery is radical penectomy. But then what we practice in total penectomy is almost to the level of the crura. So that is good enough.
Good enough. Okay. And the question that is asked is, should be done at what time? That means indication for radical penectomy. I think that is the question, or that is the intent of that question. How do you decide, Vivek, on table whether to go for radical penectomy or a total penectomy? Normally, in total penectomy, we actually take the crura also out. No, that is what is total penectomy. I think.
Yes, sir. That is till we see the bone level, and then till the crura is what we tell.
Okay.
Sometimes it is synonymous with the total penectomy and the radical penectomy. But in total penectomy, as such, they did not go till the crura. Rather, till the level the bifurcation where the crura, at that level, they will cut it off and they will make it as total penectomy.
Okay.
So that is what they term total penectomy. But by all means, total penectomy includes till the level of crura, as you rightly mentioned, sir.
I think that answers that question. Okay. Anybody else has got any doubt? Or if there are no, time is already 12:13 now. Maybe we can call it a day if there are no further questions.
Yes, sir. Yes, sure.
Yeah, Aravind? Okay. The Kaushik there in the morning.
Sir, I have asked one question, sir, about the metastatic lesion, sir, in the board.
Metastatic lesion to penis. Book says priapism is the most frequent sign in metastasis to penis. Why? Rajan or Bhavya? Whose topic was that?
Rajan, sir, has done the
Rajan, would you like to answer this question, Rajan? Metastatic lesion to penis. Why priapism is the most frequent sign in metastasis to penis?
So it's not most frequent, sir. Like mostly patient will have only pain and nodule only. So priapism will come at later stage only.
No, but why do you get priapism in patients with metastasis to penis?
Exact pathology.
Sorry? Chandramouli, if you have the answer, you can tell us also. I am also not very sure of the answer.
No, sir. The new Campbell says in the metastasis, in the bold letters, it says the most frequent sign of penile metastasis is priapism. And then penile swelling, nodularity, and other things come, sir. So
Okay.
I don't also have the answer, sir. New book says this.
I'm not very sure why it is. Maybe we can discuss that. Chandramouli, you can just read about it and let us know in the Qs group also.
Okay, sir. I will
Please read about it and let us all know. Okay.
Thank you, sir. Thank you.
Yeah, Chandran. What was the other question which Dr. P.V. Srinivasan asked, which we said we'll find out, and Bhavya, just keep track of that also. We will discuss that.
Yes, sir. Yes, sir.
Yeah. So thank you so much, Dr. Srinivasan Ganesan, Dr. P.V. Srinivasan, who have taken all your time and effort, and on a Sunday morning, Dr. Venugopal Reddy, your presence here, your expert comments are so invaluable. Hari Sudan. Hari is still there? Hari? He left, I think. I could not see his. Okay. Thank you, Hari, and Dr. Velmurugan could not join us here. Dr. Vivek, your comments are so invaluable. I think Dr. Vivek has spent 1 year of his time in one of the premier centers in uro-oncology, and your expert comments are so invaluable. And Dr. Aravind, I could not interact with Aravind today. I saw him. I think Kaushik also I saw. I could not interact much with them. Thank you all for joining us. I hope it was a useful session for you. Any further questions, we can always discuss further in the Qs group. If at all anybody has any further questions or doubts to get clarified from exam point of view or from practical point of view, we can always discuss that in the WhatsApp forum also. Okay. Thank you all, Dr. Srinivasan.
Thank you, Mr. Thank you, sir. Thank you, sir.
Thank you all. Yeah, please.
Thank you, sir.
We will call it a day, Venkatesh.
Yes, sir.
Can we all log out? Yeah.
Thank you, sir.